So welcome, class of 2013, to the UC Davis 11th Annual Mini Medical School. Yay! My name is Dr. Calvin Hirsch. I'm the interim director of the Mini Medical School. Dr. Michael McLeod, the founder and director of the Mini Medical School, this year is taking a sabbatical after running the Mini Medical School for 10 consecutive years. I think he certainly deserves that break. Dr. McLeod and I run the internal medicine geriatrics clinic at UC Davis Medical Center, where we train medical students and residents in geriatric medicine, the only place on campus that does that. And we have the only, just the two of us, provide the only teaching of medical students in geriatrics at UC Davis. It's not enough, but we do that. So Dr. McLeod, as I said, is a fabulous colleague, and he's been a wonderful educator and a wonderful teacher, and Dr. McLeod has always been willing to lend a helping hand when I asked him. And as you can tell, maybe not, I have always looked up to Dr. McLeod. Now, actually, this was a demonstration of the hip protectors. People who have frail bones, osteoporosis, are recommended to wear these so they don't hurt themselves. You could see that I didn't. And yes, they normally go underneath the trousers. This was just a demonstration. So we have an exciting curriculum for you this year, 8 lectures over 4 weeks. We're going to explore new areas in the diagnosis and treatment of Alzheimer's disease and depression. We are going to explore new areas in osteoarthritis to keep you as mobile as possible for as long as possible. We're going to explore advances in non-invasive cardiology, where things that 10 years ago required open heart surgery can now be done without a single cut of the scalpel. Very exciting. And we're going to have a lecture on allergy and immunology to tell you about you and your nose, which may be running this time of year. And we're going to have some lectures on health services and geriatrics. You're going to learn about how the Affordable Care Act might impact you when you get on Medicare, and you'll learn about polypharmacy. And we're going to have a fabulous lecture delving into the mysteries of medical forensics, of historical forensics, kind of a whodunit, and why did some very famous people die. This is going to be a very exciting session. So, we are preparing you, helping to prepare you for life's second half, and so that when you reach old age, way, way down the road in the future sometime, you can confidently stand in front of the mirror, look yourself squarely in the eye, and boldly state, "I'm ready. Bring it on." So, and we bring you the Mini Medical School. This is now our 11th year, and for 11 consecutive years, our Mini Medical School is free of charge. All faculty donate their time, but there are real, honest expenses in putting on the Mini Medical School every year. There are staff in the internal medicine who spend a fair chunk of the year working on the Mini Medical School. We all have experienced the downturn in the economy. Now it's turning around a little bit, but with a downturn in the economy, the state reduced dramatically funds to the University of California, and thus the flow of dollars to the UC Davis School of Medicine went down to a trickle. Programs contracted. Some programs in aging, like the Academic Geriatrics Resource Program, actually folded after more than 25 years. We are committed to bringing you the Mini Medical School free for years to come, but we need your help and support to do so. We need to become a self-sustaining resource for the community. We are committed to doing this, but we need your help. Otherwise, we'll disappear. And so how many of you listen to public radio, KXPR, KXJZ, KVMR? How many people watch KVIE public television? How many of you have made a donation to public TV or public radio? So I hope that you will consider making a donation to the UC Davis Mini Medical School so we can continue to bring you free lectures like this every year to prepare you for life's second half. We'd like to thank our corporate sponsors, Safe Credit Union. They have representatives out in the lobby if you'd like to talk to them at intermission. The Eschaton Corporation and the UC Davis Department of Internal Medicine. And we'd like to thank our volunteers. You've seen them. They've handed out the programs. They've set this up. They take this down. They are a remarkable group of people. We'd like to thank our past, present, and future volunteers. So give them a round of applause. And we'd like to thank our fine Mini Medical School Advisory Committee who have helped us move along in the right directions. And if there are any members of the Advisory Committee in the audience, would you please stand up to be recognized? There are more than one, thank you. But most of all, I want to thank you, the audience, because obviously, if there wasn't you, there wouldn't need to be a Mini Medical School. So I want to give you, from us, a great special thanks and an applause. All right. Now we're going to go to some house rules that are fairly important. I need to make sure I have my special extra notes here. The first and foremost thing is that the badge that you have is your admission ticket, so that you need to bring that every week, otherwise there's a possibility you might not be admitted. You never lose your driver's license, we hope, so don't lose your badge. That's your admissions ticket. That's your season pass to this year's Mini Medical School. There's also, I think most of you have received a consent form for videotaping, new and fancy rules from the University of California. We have a videographer today, and he may want to pan the audience, especially those people who ask questions. So if you can, please sign the consent form, unless you really don't want to have your face amongst the millions here at broadcast. The other house rule is please hold your questions until the end of the lecture. And try to keep your questions broad enough so that they are germane to the rest of the audience, and please don't ask personal medical questions. And we have people with volunteers with microphones who will come down and pass you a microphone. Please wait to ask your question until you actually have the microphone so we can all hear you. And please silence your pagers. And I think I ought to do that myself here, huh? And cell phones, okay. And I can't talk and do this at the same time. I'm sorry. Also, don't chew gum and walk at the same time. I can't see this thing. Okay, we'll just talk. All righty. Well, now we'll turn off my cell phone here. Better practice what I preach. Okay, so we're going to go on to the first lecture. I apologize if he's going to bore you. It's me. So today we're going to talk about polypharmacy, the good, the bad, and the ugly. And I have no financial disclosures. After all, I'm just a geriatrician. Well, polypharmacy, I suppose, could be defined as the presence of lots of drugstores in your neighborhood. But we are going to talk about taking a lot of medications. Does this bathroom scene, is this familiar to any of you? I hope not. This came from one of our patients. So the question is, polypharmacy means multiple medications, but how many medications really are polypharmacy from a clinical standpoint? There was a study done looking at 1,705 men enrolled in a health and aging project for men called the Concord Health and Aging Study. And they found that taking 5 or more medications predicted becoming frail, predicted becoming disabled, having falls, and predicted an early death compared to those who are taking fewer than 5 medications. So it has become convention that 5 or more medications is what we refer to as polypharmacy. So do medications cause sickness, and should medications be avoided? There are a lot of folks who are afraid of medications, and we have to treat them with respect. But there are obviously beneficial factors about taking multiple medications. First and foremost, the standard of care for many chronic illnesses today, like congestive heart failure, require that a person be on multiple medications. And the reality is that polyillness, multiple medical conditions, is common. This is a study that looked at the prevalence of taking 4 or more medications, or sorry, having 4 or more medical conditions in different age groups, 65 to 69, 70 to 74, 75 to 79, and 80 to 84 and above. In the 65 to 69 age group, almost 16% had 4 or more chronic conditions, but by the time you got to the 80 to 84 and plus groups, about a third were taking, over 30% were taking, had 4 or more chronic conditions. So as we age, the probability of us having multiple chronic diseases increases. It's something that, frankly, most of us can expect. By the way, all of this is in your handout. There's no need to take copious notes if you don't want to. So basically, taking medications is going to be a balance between the potential benefits and obviously the potential side effects. We can also look at it from a different perspective. It's really the selection of appropriate medicines versus inappropriate medicines, rather than an issue of how many medicines we take. So we're going to do what we do in medical school. We're going to do a case study. We're going to bring this from theory and epidemiology right down to the bedside. So we have Mrs. D, a real patient. Well, she didn't look quite like that, but close. She was a 77-year-old obese woman who had a lot of chronic diseases, diabetes, high blood pressure, heart failure, moderately severe kidney disease, high cholesterol, heartburn, bad arthritis of the knees. She had a burning neuropathy in her feet, which was very painful and disabling for her. She had bad eyes with glaucoma, she had depression, and she had insomnia. So in addition to her primary doctor, she was seeing an endocrinologist, a cardiologist, a neurologist, a psychiatrist, and an ophthalmologist. And I forgot to put in, she was also seeing a podiatrist. So that's a lot of ists. And these were the 13 of Mrs. D's prescription medications and the 1 over-the-counter medication, OTC, at the bottom right-hand side. The Sominex, which is a sleeping medication containing diphenhydramine. So what is your guess that there may be some potentially inappropriate medications in this medication list? Anybody think there might be? You do. Wise people. Well, she had 8 potentially inappropriate medications. The medications amitriptyline, clonazepam, ranitidine, diphenhydramine, and Vicodin, which is acetaminophen and hydrocodone, all can potentially cause confusion. Metformin, a diabetes medication taken at her dose, given the fact that she had moderate to severe kidney disease, could, if she got infected, lead to a fatal lactic acidosis. And she was taking metoprolol for high blood pressure and timolol for glaucoma. Well, these medications actually are of the same class, called beta blockers. The timolol is an eye drop, but it does get absorbed into the bloodstream. So what can happen if you add timolol to a beta blocker like metoprolol is that you can get a further lowering of blood pressure and a further lowering of heart rate. This is how this lady came to our clinic. So how come doctors don't pick this stuff up? Well, when you start going to a lot of specialists, specialists do what they do best. They focus on their specialty, and they may not be aware of the best treatment of other medical conditions. There's also sometimes not the best communication among doctors. The primary doctor may not even hear about the new medication until he or she sees the patient, sometimes months later. The doctors are supposed to send a note. Sometimes the doctor doesn't see that note until the next visit. And many doctors, even excellent doctors, may not be aware of all of the age-associated side effects of medications and drug-drug interactions. There's just too many drugs and too many interactions to know. And the other thing is that there is this, the specialist knows best syndrome. A lot of primary doctors assume that the specialist knows best about their condition, so whatever they prescribe is obviously wise and smart and appropriate. It ain't necessarily so. I'm not knocking the specialists, but sometimes their choice of medications fails to account for other medical conditions or issues. So, our friend Mick, how does the aging process affect the way we metabolize drugs? I suppose we could say, how do they affect the aging process? The amazing thing about Mick Jagger is he's still around and he's still dancing. I just don't know how he does it. The blue represents older age, and the green represents, in the little homunculi, represent physiology at the age of 20. And what you can see is that there's about a 35% increase in body fat, an 8% decrease in plasma volume, a 17% decrease in total body water, and about a 40% decrease in extracellular fluid. All of this fluid decrease really comes because there's an age-associated decline in muscle mass, which leads to a proportionate increase in fat mass. So even a thin older person has proportionately more fat and less muscle than a younger person of the same body habitus and weight. Some of that's alterable, and you've heard me in the past say that exercise helps maintain muscle mass. So some of these age-related changes in the way drugs are metabolized comes because of these age-associated changes in body composition, as well as the way our body organs change in function, especially the kidney and liver. And there are two types of age-related changes in the handling of medications that I'd like you to know about. The first is pharmacokinetic. What this means are changes in the time course associated with how a drug is absorbed, how it's distributed throughout the body, through the bloodstream, in tissue that has water and in fat tissue, how the drug is metabolized, whether by the liver or in the kidney, or whether it's not metabolized at all, and how the drug is eliminated and the time course of that elimination. Pharmacodynamic, on the other hand, refers to changes in the action of the drug. Let me give you an example. Benzodiazepines, Valium. Everybody's heard of Valium, Ativan, Xanax. Those drugs have more effect on balance in older people than they do in younger people. They also are more likely to cause confusion in older people than in younger people. Taken at the same dose, the same milligram per kilogram of body weight, so you adjust for the size of the person, and they still have a greater effect. So there's a qualitative difference in the action of the drug as well as a quantitative effect. This is why benzodiazepines, the Valiums, the Xanaxes, the Restorils, the Ativans, increase the risk of falls in older patients. And this risk stays there even for 2 weeks after a person stops the drug. So that hip fractures have been associated with these medications even in those who stop them 2 weeks prior to the hip fracture. They stay in your system and the effects in the brain can linger. An example. So we're now going to move on into the epidemiology of polypharmacy in older folks. And here's a study that was an Australian National Census of Medicine's Use, done in 2009 to 2010. And it said it was a survey, and it asked people over the age of 50, what drugs, prescription and over-the-counter, did you take in the last 24 hours? So the blue is basically 1 to 4 medicines, the flesh tone is 5 to 9 medicines, and the green is more than 10 medicines. And as you can see, the portion of people taking 10 or more medicines increases. What's interesting in Australia is that women over the age of 75 took about 30% of those women over 75 took 10 or more medications, but only about 15% of men over the age of 75 took 10 or more medications. And I'm not sure if this is unique to Australia or it's just something about guys and being too macho to go to the doctor. But this was a study looking at polypharmacy among older adults admitted to hospital. It's a Veterans Administration study, so it looked at men. And this was a retrospective study, so it took 678 randomly selected, unplanned admissions to VA hospitals, all 152 VA hospitals throughout the United States between 2003 and 2006. That was a total of almost 2.5 million hospitalizations. They took a sample of 678 of these people that were representative. So about 35% of these folks took 5 to 8 medicines at admission, and about 45% took 9 or more medicines, and their average age was 76. So polypharmacy is common in those being admitted to hospital. This was a study of polypharmacy in nursing homes. It was a European study called the Shelter Study. It looked at 57 nursing homes in 7 European countries between 2009 and 2011. And there were about 4,000 residents they surveyed, average age of about 84, and about a quarter took less than 5 drugs, about half took 5 to 9 drugs, and a quarter took more than 10 drugs. That means that 75% had polypharmacy as we define it. So what are the reasons for polypharmacy? Well, polyillness, multiple illnesses. This happens to be data from the Women's Health and Aging Study, mean age of 78. And as you can see, the study looked at 9 selected chronic conditions that they adjudicated. That is, that they all agreed that these people had this condition. They could have had other conditions too. But so if a person had none of these adjudicated, I can't speak, and I'm still not chewing gum. If they had none of these adjudicated conditions, they were taking an average of 4 medications. But by the time they had 6 of these adjudicated conditions, they were taking an average of 9 or more medications. So again, more illnesses, more drugs, no surprise there. But there's some other reasons for polypharmacy. Multiple drugs for individual conditions. I mentioned heart failure. If you have heart failure, systolic heart failure, you're probably taking a diuretic, you're probably taking a beta blocker and an ACE inhibitor, and maybe a drug called spironolactone or something similar. So 4 drugs potentially as standard of care for more advanced forms of systolic heart failure. And we've got more drugs in the pipeline. We've got more drugs for more conditions, and we now have, and established drugs are developing new indications for their use. So as an example, the antidepressant drug duloxetine was originally created for depression. Then it became indicated for neuropathic pain, as in diabetes. Then it became indicated for osteoarthritis. 1 drug, 3 conditions, 3 opportunities to prescribe, more opportunities to prescribe the drug. And unfortunately, there are doctors who prescribe drugs to treat the side effects of drugs. Don't laugh, it's a problem. There are some justifiable incidences. For example, if one has severe pain and has to take an opioid-containing medication, opioids like Vicodin can cause constipation, it's appropriate to prescribe a laxative. And if a person has arthritis and you want to prescribe a non-steroidal anti-inflammatory drug which can cause irritation of the stomach lining, it's appropriate to prescribe an antacid if that NSAID is necessary. But most of the time, unfortunately, doctors may not realize that the symptoms they are treating are side effects. So here are examples of unjustifiable use of dangerous medications for the treatment of side effects caused by drugs that we saw in our geriatrics clinic when the patients came to us in consultation. We had a patient taking an antipsychotic medicine that was prescribed for hallucinations that began after this patient started taking the medication Requip for restless leg syndrome. Most people don't get hallucinations. It's a good drug, but this person did get hallucinations and it's a known side effect. Should this person be on Requip? Probably not if there are other alternatives. We had another patient, actually this has occurred multiple times. We've had patients come in taking the anti-incontinence drug oxybutynin, otherwise known as Ditropan, because the patient was having nighttime incontinence. Because they were taking a diuretic at nighttime. Give me a break. And there are patients who go to their doctors and say, I want this drug because I saw it on TV. So this is a cartoon from The Wizard of Oz, and the servant is asking the wizard, why are they advertising prescription drugs? And the wizard replies, so you can tell your doctor what you need. And the servant replies, well, too bad he wasted all that money on medical education. So what are the consequences of polypharmacy? By the way, I'm not my own timekeeper, so if I'm getting late...
what time do you want to be?
Well, I think I'm doing okay, actually. I think I'm doing okay. My wife always says I'm long-winded, so I have to be careful. And when I'm at the dinner table, my daughter always used to say, Papa, please keep quiet. So what are the consequences of polypharmacy? First, we have to go to the medical dictionary and define what is meant by non-adherence. That sounds like something like you'd hear, in 1984. Take that person away, she has been non-adherent. But what it means in medical terms is failure to follow the directions of a prescription or treatment, either from not taking the medication or taking it incorrectly or in a way different from that prescribed. So non-adherence to polypharmacy is probably the most common consequence of polypharmacy. This is the Medication Safety Review Clinic Taiwanese study, which looked at 193 Taiwanese patients, average age 76, who are taking an average of nearly 9 drugs. The study investigators defined non-adherence as taking a less than 80% or more than 100% of a medication. By this definition, a third were not adherent with at least a quarter of their medications, and no surprise, adherence got worse when they had to take a drug multiple times during the day. Cost is also a big factor in polypharmacy. Let me see if I can maneuver my thing. The blue bars refer to all seniors, the red bars just to those seniors with 3 or more chronic conditions. If you look to the right here, for all seniors, 26% did not take their medications as prescribed because of cost, but when they had 3 or more medications, a whopping 35% didn't take their medications because of cost. And the reasons are multiple. Some did not fill the prescription because it cost too much. Some skipped doses to make the medication last longer, and some took less of a dose, like half a pill, to make the medication last longer. Now, I admit this study was done in 2003, before the Medicare Part D plan came into effect. But even after the Medicare Part D plan started, the copays for many medications still are astronomical. I think most of you who have Medicare D and use it probably agree. So cost is a major barrier to adhering to drugs. Drugs also have potential serious side effects. This is a study that was done on nearly 47,000 patients enrolled in Kaiser Permanente, Northern California, who had a diagnosis of diabetes. And they followed these patients for 5 years looking for incident falls. And they looked at the risk for falls, in statistical terms, the hazard ratio. But they statistically adjusted for the patient characteristics, their age, their gender, other diseases that they had, and prior hospitalizations. And the reference, which is not shown here, is that they weren't taking any medications. Everything highlighted in yellow is statistically significant. So the more medications a person was taking, the greater the risk of having a fall over the next 5 years. It was true not only for people over 65, but for 65 and younger. And overall, if a person was taking over 7 medications, they had a 59% greater risk of having a fall than people who were not taking medications. So polypharmacy can do bad things. The potential for drug-drug interactions in a patient goes up with the number of medications that person is taking. This was a retrospective study of nearly 82,000 Taiwanese outpatients done in 2004, and they restricted the study to patients who had at least 2 prescriptions and had been using the medications for at least 2 weeks. And as you can see, as the number of medication increases, the potential, based on computer algorithms, the potential for drug-drug interactions rises exponentially. And no surprise, the potential for drug-drug interactions also rises as a function of age, because older people have more chronic conditions and are more likely to be taking multiple medications. So adverse drug reactions and adverse drug events are serious consequences. These are used fairly interchangeably in the literature, although they have slightly different meanings and definitions. So I've come up with an inclusive definition that incorporates both of these terms. And the definition is that an adverse drug reaction or adverse drug event is harm resulting from the use of the drug taken at the doses that we normally prescribe for humans, or it's harm resulting from the way the drug was given, for example, given as a wrong dose, or not given at all, or not taken at all. The risk of adverse drug reactions is a function of pharmacokinetics and pharmacodynamics, which we have seen changes with increasing age, and it's a function of polypharmacy, as well as drug-drug interactions. So here are some consequences of adverse drug reactions in older patients. In the United States, it is estimated that about 1.5 million preventable adverse drug events occur annually, costing to the tune of about $4 billion. Lazarou and his colleagues back in 1998 published an article in which they estimated the incidence of hospitalizations caused by serious and fatal adverse drug reactions back in 1994. They took a sampling of these admissions and then extrapolated to the population at large. So the estimated incidence of adverse drug reactions in US hospitals in 1994 causing a serious hospitalization, these were serious adverse drug reactions, caused a hospitalization, were 4.7 admissions out of every 100 admissions. And adverse drug reactions were estimated to be responsible for 13 out of every 10,000 admissions to a hospital. So we've looked at this veteran study before, the one that looked at 678 randomly selected unplanned admissions out of 2.4 million. They found that about 10% of total admissions were due to an adverse drug reaction. 36.8% of these adverse drug reactions by expert committee were deemed preventable. And again, if this isn't becoming obvious, nothing ever will, adverse drug reactions were significantly associated with the number of medications. In those with an adverse drug reaction related admission, only 7.4% were taking 0 to 4 meds, but almost 59% were taking 9 or more medicines. But I can't fail to mention the fact that most people with polypharmacy don't have adverse drug reactions. Of the 264 in their study who were taking more than 9 medications without an adverse drug reaction, well, 264 or 43% of those did not have an adverse drug reaction despite their polypharmacy. So it's still a relatively rare event. So how can we handle polypharmacy in the older patient? Specifically, what can we do? Well, we can take the nihilist approach and just say, medications are too darn dangerous. I'm going to go naturally and not take any prescription medications. And you would be in good company because none other than Sir William Osler at the end of the 19th century was famously quoted as saying, "One of the first duties of the physician is to educate the masses not to take medicine." However, in his time, medications were things like paregoric and laudanum, and who the heck knows what was in the patent medicines because there was no regulation at that time. So in 1880, he was probably right. But I'm not sure that in an era where we have effective medicines, that approach is sensible. You could take what I call the carination approach. You can chop your medication list, trying to only take the essential drugs, but who the heck knows what really is essential? I mean, your drugs are given to you for a purpose and they work often synergistically, so we're not really able to judge that. So what we need is a more modern, intelligent design for physician prescribing. We need to evolve what physicians do, and that means finding a new, evolved prescribing paradigm entailing the recognition and minimization of potentially inappropriate medications, or PIMs. You've heard about these before. So how do we define a PIM? It's a medication that poses more risks than benefits to older adults, either by itself or considering the availability of alternate treatments. So what happens if people take PIMs? PIMs are found in about 35% of older patients admitted to a teaching hospital. This was in Ireland, but a representative study. And of this 35%, a third presented with an associated adverse drug reaction. So PIMs increase the risk of an adverse drug reaction or event by about 43%. In older people living in the community, the estimated extra cost attributable to PIM use way back in 2001 was $72 billion, with a low estimate of $3.4 billion and a high estimate of $15.7 billion because of the added cost of PIMs and the reactions. Well, no doctor, no patient can know and memorize all harmful side effects of every medication. That possibility sort of went the way of the times of Sir William Osler, when there were maybe a dozen or so medications you might prescribe. It's not going to happen today. So a list of PIMs can be a useful tool for safer prescribing. Doctors ought to have this list in front of them. Doctors usually don't. But you can have one, not to decide what to take, but to use it to help your doctors make the safest choices. There are several tools that are for identifying PIMs. The most well-recognized and widely used are the Beers criteria, named after a late colleague, Dr. Mark Beers from Harvard, who developed a list with an expert panel for nursing homes. That's what SNF means, skilled nursing facility, back in 1991. And then in 97, this list was expanded to all healthcare facilities. And it was updated in 2003 and most recently this last year. And To do this, Dr. Beers gathered a 11-member expert panel consisting of geriatricians, nurses, pharmacists, and experts in health quality measures. They first screened a total list of over 25,000 citations that discussed side effects of medications. They looked at monographs from drug companies, and they culled this down to a little more than 2,200 and something citations, and then they reviewed in depth 2169 citations to come up with the Beers list. It was an enormous amount of work by this expert panel. And this is what the criteria look like. And they're organized, the medications are organized by organ system, therapeutic category, as well as by disease or syndrome. And it's useful, but it can only be useful if it's readily accessible. Why don't doctors use it more often? Well, one reason is that when the article came out, it was 16 pages long, and it doesn't fit very well in a lab coat. Fortunately for all of us, the Beers criteria are now available free of charge as an app on the iPhone and iPad. And your handout has the web address and how to actually download this for your iPhone and iPad. And if you don't have either one of those, you can get a condensed version, kind of a pocket guide that you can download free of charge. Anyone can go onto the website and download this. All you have to do is go to AmericanGeriatrics.org, and then in the search bar, type Beers list or Beers criteria, and voila, there you are. Download it, you're fine. Now, if you don't have a printer or don't have ready access to the internet, there are a limited number of copies of this handout available as you exit for the break by either door. But if you have the ability to download it, please do, so that those who can't will have a copy. So you can. This is something that you can get and should get as a help to help your doctor help you. So we're going to conclude with a few questions that you can ask the doctor who is prescribing for you or a relative. First, you want to know if you can multi-purpose a drug. So we don't want to just pare down our medication list without thoughtfulness, but if we can pare down the medication list by multitasking, if you will, a single drug, so it can be used for multiple conditions, let's do that. So for example, if a person is depressed and they have a poor appetite, you can give them a drug called Remeron because it treats depression and it stimulates appetite. We want to know if the drugs are going to cause or exacerbate so-called geriatric conditions, the most important of which is cognitive impairment. Does the drug cause new confusion? Does it worsen dementia? Or does it cause confusion and agitation on top of existing dementia? Some of the biggest offenders are so-called anticholinergic drugs. This is all in your syllabus. So you should be cautious of first-generation antihistamines. These are things like diphenhydramine, chlorpheniramine, hydroxyzine, meclizine. These are used in over-the-counter allergy drugs, cold remedies, anti-itch medications, and anti-dizziness medications. The second-generation antihistamines for allergies are available without a prescription, and they're safer. Drugs like loratadine or Claritin or cetirizine or Zyrtec. Be cautious of anti-nausea medications, things you can buy over the counter, and things you can't. Scopolamine, Dramamine, Compazine, Phenergan, and be cautious of first-generation drugs for urinary incontinence. Ditropan, Detrol, and ask your doctor if you're going to take these medications for safer choices like Enablex or Vesicare. Be cautious of anti-anxiety drugs. We've already talked about the benzodiazepines. Sleeping pills like Ambien, Restoril, Lunesta, and opiates like Vicodin and Percocet. They may be necessary, but they may cause confusion. Be aware of the increased risk of falls. Benzodiazepines and related drugs. We've talked about that. Drugs that can cause clumsiness, like the anti-seizure drug Dilantin. Drugs that can cause the blood pressure to fall when standing up, which is many blood pressure pills. Drugs that can cause dizziness or a sensation of disequilibrium, which applies to any seizure medication, many of which are now used routinely to treat the burning neuropathies in diabetes or other neuropathies, and any drugs that cause drowsiness. And there's another reason to avoid PIMS. The caption reads, "We medical practitioners do our very best, Mr. Nyman. Nothing is more sacred to us than the doctor-plaintiff relationship." So here are some take-home messages so you can all hurry off to the bathroom. Polypharmacy is almost inevitable as we age, unless you are very, very lucky. Polypharmacy increases the risk of adverse drug reactions, but it can also be part of the optimal treatment of medical conditions. So the goal is not eliminating drugs, it's smart prescribing. Minimize the number of PIMs. If the doctor recommends a drug that's on the PIM list, ask the doctor, are there safer alternatives? What's the impact of the drug potentially on geriatric syndromes like confusion, incontinence, and falls? Can the drug regimen be simplified? And the Beers list is a handy tool for you to take with you when you visit your doctor. But remember, it's only a guide, it's not a list of never medications. So with that, happy pill taking.